Assalamu alaikum. I welcome you all in the 8th session of Pakistan Endocrine Society Annual Conference 2024. And today's session theme is How Do I? And for this session, I would like to call upon the stage as a panelist, Dr. Gulshad Hassan. Sir is the head of department of the Bahariya International Hospital, Lahore. And he is the author of the handbook of people with diabetes, and it's published in many of the different languages. Sir Gulshad Hassan, please come on the stage. Our second panelist is Dr. Uniba Syed, and she is the assistant professor of Allama Iqbal Medical University. She is the vice president of the Pakistan Endocrine Society Punjab chapter, and she is also the co-chair of organizing committee. Our third panelist is Dr. Mahwish Iftikhar. She is the assistant professor of endocrinology at the Services Institute of Medical Sciences, Lahore, and she is the executive member of the Pakistan Endocrine Society. Ma'am, please come on the stage. Now move on the talks. So the first talk is on the topic of screen for MASLD and its progression in people with diabetes. And for this, I would like to call Dr. Ali Karamat, and he is the consultant physician and honorary professor at the Birmingham Hospital, UK. Sir, please.
Thank you very much for the introduction, and it's always a pleasure to be back here in Pakistan, and I'm really grateful to all the organizers, particularly Dr. Aisha Sheikh, Dr. Umar Raja for inviting me. Really grateful to you. Always have a lovely time coming to Pakistan, so thank you very much, and I look forward to being part of the rest of the sessions as well. So the talk that I'm giving today is how to screen for metabolic associated steatotic liver disease. Now, this is my humble abode where I work, Birmingham, or as I like to call it, the capital of British Pakistan. So that's where I work. MASLD is a huge problem which is developing more and more now as we are finding it and as we do more and more investigation. So what I'm going to talk today is a little bit about how to screen and actually more around some of the risk factors and what kind of things you might want to do to try and pick up MASLD. So the first factor is, why do we actually have such an issue with metabolic associated steatotic liver disease? And throughout this conference, one of the themes that has come about is regarding the raised body mass index, the obesity epidemic that we are dealing with. And this is just a picture from comparison between 1975 and 2014 in terms of the percentage of adults who you would define as obese, and how whichever part of the world you live in, you can see quite clearly the prevalence of obesity rising as we go along. And in 2019, almost 7 out of 10 men or 6 out of 10 women would be classed as overweight or obese in the last data that you had from the National Health England data from Public Health. And it's not just a problem in the Western world. When you look at any of the areas in the world, you can look at the prevalence of NAFLD and see how it goes along. And we'll talk a little bit in the beginning of my presentation about the terminology of NAFLD and MASLD and why we've moved away from the phrase NAFLD and now why we are talking about MASLD. And if you're looking at prevalence around South Asia, Southeast Asia, you can quite clearly see the prevalence is even higher than some of the other areas around Western Europe if you're looking at MENA and South Asian regions. Now, what is in a name? So we don't like to call it any longer non-alcoholic fatty liver disease as it used to be in the beginning. So this term was first coined in the 1980s, and one of the reasons why this was changed was because of the mention of alcohol in the name firstly, and also talking about the stigma of using the phrases like fatty and non-alcoholic in the name of the condition. And also you have to remember that as things are going along with the rising prevalence of obesity in kids, you're actually having a problem in the pediatric population as well. So you need to have a coined entity which actually would encompass everything and not just one particular area. And you can see on the right hand side in terms of the interaction between body mass index and alcohol, which is still considered one of the big risk factors in the Western world in terms of metabolic liver disease. Now, when we talk about steatotic liver disease, or as you would say, deposition of fat leading to liver disease, this is kind of some of the entities that we use the phrase. So what we'll focus more on as a part of this talk will be in the first one, which is MASLD, or metabolic dysfunction associated steatotic liver disease, and then MASH, or metabolic dysfunction associated steatotic hepatitis. Then you've got the interaction, as we've talked about earlier, between alcohol and MASLD, and MET-ALD is the phrase which is used for that now, where you can look at which of the two elements are predominant. Then you've got obviously the common ALD, and then specific etiology of steatotic liver disease, where you may find that it's related to a drug injury or monogenic diabetes diseases, and then finally where you may not be able to find a cause which is classed as cryptogenic. And these are some of the stages of liver disease. So you start off from a healthy liver to some fat depositions, and then you get to the stage of hepatic fibrosis, and that's really where it is important to intervene and understand and try and look at how you can pick up at that level. And then you eventually get to the stage of liver cirrhosis, and in some instances even the risk of hepatocellular carcinoma. What matters actually in steatotic liver disease is when you get to fibrosis. So with the prevalence of metabolic dysfunction, raised BMI and everything, you would find perhaps some deposition of fat in a lot of people, and the significance of that is important, which is why it's more crucial, as this graph shows, to talk about fibrosis, because that's where the Kaplan-Meier curve suggests the survival goes down and people start dying from liver fibrosis and its complications. So this is a study which was published in the New England Journal of Medicine, which talks about clinical outcomes in adults. At that time the phrase was still on alcoholic fatty liver disease, and it talks about the liver related events, and also it talks about death from any cause. And if you're talking about the liver related events, what was quite clear was that between the stages of F0 or F2 histologically, there was no mild or moderate fibrosis, and there was no real risk as such of the liver related events. But as you get to bridging fibrosis or eventually to cirrhosis, the risk increased for all the liver related events such as ascites, variceal bleeding, encephalopathy, hepatocellular carcinoma, and also death from any cause. And that became even worse when you got to the stage of liver cirrhosis. And one of the issues that we get is a lot of times, and even when I practice in the UK, you see this still happening, where actually the first time people are presenting, and actually they are presenting at the stage of cirrhosis, and you've missed the boat by then because you've actually not identified MASLD early enough to be able to address the risk factors. And as this study showed, about almost half of the cirrhosis in this condition was diagnosed after and first emergency presentation. And some of the data from hospitals or secondary care suggested that only about 13% actually was seen in a liver clinic more than a year before. So really a lot of these people are missed out and not actually referred or seen in the liver team but at the right time. So how can we find these people? The important point here is addressing the risk factors, and you talk about addressing risk factors such as diabetes, obesity at the stage of liver fibrosis, and making sure it does not progress to the other stages of cirrhosis, and then the mortality doesn't come. And that's where some of the more non-invasive investigations can be useful. So what do we mean about some of the tests that we can do for metabolic dysfunction associated liver disease? On the left hand side are those biomarkers which are not that expensive, and some of them are patented, some of them are not patented. So if you talk about our experience in the UK, on the left hand side, the four which are rare are the commonest ones which I have most experience with and we've used in the UK, which include the AST-ALT ratio, the APRI, the FIB4, and the NAFLD fibrosis score. And the next few slides I will elaborate on particularly the NAFLD fibrosis score and FIB4 in a lot more detail, because those are the two that we use most commonly in a lot of our liver centers. And then on the right hand side, you've got the more costly interventions, which a lot of them would be carried out by our colleagues either in the liver clinics or in radiology departments, and they're essentially measuring the liver stiffness. So you've got the magnetic resonance imaging, and you've got the sonography and fibroscans and so on and so forth. So though they are more expensive and they are more commonly available in liver clinics or radiology, and then the biomarkers you can do in your own centers. So this is a little pathway that we have developed locally in our own hospital as to what to do if you see somebody presenting with deranged liver enzymes, whether it is ALT or AST. So you do the other liver blood tests in the first instance. You can do an ultrasound scan and do the liver etiology screen, which includes Hep B, C serology, and autoantibodies. And then if you've got features which are more consistent with the NAFLD or MASLD, which include type 2 diabetes, BMI, dyslipidemia, hypertension, then you'll go down the fibrosis algorithm, which we'll talk a bit more about in the next section. But if the other aspects are, then you go down completely to the right-hand side, which is not necessarily the purpose of this talk, but the left-hand side will focus on a bit more. So let's say we've got suggestion from the imaging and the liver screen is negative. So then you're actually looking at how you determine whether they are at risk of advanced fibrosis. As I said, a little bit of deposition of fat is not uncommon to see. So it's more important that you're picking it up at the right time for fibrosis. And that's where the NAFLD fibrosis score or the FIB-4 score are really useful. So I've given some numbers here which we use. Again, you can look at it your own center. These are the recommendations, but you can look in your own practice in terms of what works practically for you guys. But the FIB-4 less than 1.3 or NAFLD fibrosis score less than minus 1.45 are generally suggestive there's a very low risk of advanced fibrosis, and you mainly are going to address the risk factors in these people. Then you've got the high risk ones, which is above 3.25 FIB-4 or greater than 0.675 NAFLD fibrosis score. Now these are the people who really are at very high risk of advanced fibrosis and ideally should be assessed by a liver doctor, hepatology services. And then you've got those in the middle of it where the role of some of these other more sophisticated imaging, which I mentioned earlier, such as the elastography, the fibroscan, magnetic resonance images comes in, and where you could use those tests. As we've said, you can modify your own settings. We've written, for example, on the right-hand side in the sort of older age, for example, higher cutoffs might be used. So these are just, this is a pathway that's been developed in my own hospital, Heartlands Hospital in Birmingham. And then this is the NAFLD fibrosis score, which uses these entities which are all available to us in common practice, so the age, BMI, presence of hyperglycemia, platelet count, AST to ALT ratio, and albumin. That's the score that you do. So we did a little project, for example, where we looked at doing a scoring like this in our general diabetes clinics, and it was not too difficult to do because we literally had this score programmed in an Excel spreadsheet, and we were able to calculate that straightforward for people when they were coming into our service. And as I said in the last slide, less than minus 1.4, there's absence of significant fibrosis with about 88% certainty. Greater than 0.67, presence of significant fibrosis at about 82%. It's the intermediate ones where you need to do a little bit more work to try and figure out which class they fit in. And then you can look at the FIB-4 score. This is probably the most validated amongst the many which are tested. And again, it doesn't require a lot of parameters. It's relying on age, AST, ALT, and platelet count, and the graph at the bottom is how you calculate it. Again, not that difficult to do. You can have it in your own departments, you can have it in your own centers, and it's not too hard to actually implement it. And you can look at the low probability, for example, which has got a higher sensitivity cutoff if you go to the higher side, and a higher specificity cutoff if you went towards the intermediate high range. So that's how you can use either of these scores, and probably when you're talking about how to screen, I think those are the two which I would really focus on in a clinical setting. Now, just to make sure I'm not biased, I'm showing you another pathway which is from Nottingham, which is a neighboring place through Birmingham where I practice, and again they're using similar ones, but they're relying more on the FIB-4. As I said, it's the most validated one, but the overall principle of how they're doing it is pretty similar. We've talked a little bit about fibroscan earlier, and this is some of the entities which we've said. So if the fibroscan suggests it's less than 8 kPa, this rules out essentially significant fibrosis. Between 8 to 15, you might want to consider referral, and certainly above 15, they need to be seen by the liver team. But lifestyle advice is the most important one. Just some of the histology findings, what you might see with F1 moving on to F4 fibrosis, and how they might look differently. And again, at the early stages, you might just want to go discharge to primary care. And the new entities, obviously, the antifibrotic therapies and various surveillance which are coming in. So to sort of summarize things in terms of where people can be seen. So in terms of, for us in endocrinology, the risk stratification, FIB4, nephral fibrosis score, management of other endocrine conditions, that all fits under our remit. Nutrition, lifestyle intervention falls under our limit, but when we're talking about comprehensive liver risks, liver-directed therapies, additional comorbidities, that's where you might want to get some help from the liver team. And then obviously you've got the weight management interventions, bariatric surgeries, got some good evidence here, cardiology and advanced lipid management, and some of the newer agents which are coming on as antifibrotic as well. So my take home from the talk today is it is extremely common now, MASLD. It is now really getting very close to alcohol liver disease as the leading cause of liver transplant in Western world. It is mostly due to a combination of risk factors. Important to identify people who have liver fibrosis. The liver fibroscan is a very useful test to look at that. Liver stiffness less than 8 excludes significant fibrosis, but if it is more than 8, you might want to consider a referral to hepatology. There is a lot of new treatments coming along, as I mentioned, not just from the weight loss point of view, but also antifibrotics. And there is some hope, not necessarily just hype, but what is really important is we've talked about the major risk factors of obesity. With the epidemic, with the rise of type 2 diabetes in children, I think the public health interventions cannot be ignored in management of any metabolic disorder or metabolic dysfunction associated liver disease. Thank you very much, audience.
Thank you so much, sir, for your important and very valuable talk.